This is Dr. Howard Strassler presenting the e-lecture on posterior composite resins, Module C, the challenges for posterior composites. When we're looking at the criteria for selecting a composite resin to restore posterior teeth when developing a composite resin, there are several factors that need to be taken into consideration. First, we need wear of the composite similar to that of natural tooth structure or that of dental silver amalgam. We'd like to see no plastic deformation in function on the restorative material. We'd like to have a simple technique for placement. We'd like to see minimal shrinkage during polymerization. Along with minimal shrinkage stress during polymerization, these criteria will lead to a less troublesome composite when placed intraorally. We want to have a composite that, with an adhesive technique, gives us excellent marginal adaptation and sealing. We'd like to see a radiopacity equal to or greater than enamel and dentin, so we can use it to evaluate the composite resin on radiographs for whether they're being successful or whether or not we see recurrent decay around them. Finishing composite, we'd like to have one that's easy to finish, very quick, exact, without destroying any tooth structure during the finishing process. And certainly we'd like it to be aesthetically pleasing in color and translucency for a higher patient acceptance. We've not yet found that perfect composite, but certainly in the last 2 decades we've seen advancements in adhesion and the composite chemistry to give us a composite that is functioning quite well for routine-sized restorations. In fact, when we look at the composites that we use at the University of Maryland, we're using a very highly filled composite resin, Prisma TPH3, a nano hybrid. We're also using a nano mitromatrix hybrid aesthetics, and we also have available a packable composite Quicks. We have a moderately filled flowable composite, Virtuoso Flowable, and we're using Delton Pitt and Fisher sealant for sealing teeth. So what are the advantages of direct composites when restoring posterior teeth? Certainly they're highly aesthetic. We can use a more conservative cavity preparation design with a minimally invasive cavity preparation that can be more carious lesion directed, where we remove the caries and then we restore. We're using an adhesive technique using an etch and rinse adhesive, where we're etching the tooth first with phosphoric acid, rinsing and drying, and then placing our adhesive and light curing it. In cavity preparations, routine conventional cavity preparations where our isthmus widths are 1/4 to 1/3 the intercusp distance, we actually find that we're getting tooth reinforcement. And for those concerned with the fact that amalgam contains metals and mercury, composites are mercury and metal free. Now there are some disadvantages, and you can't sense this from having placed it on a typodont, but placing posterior composites are more technique sensitive. It requires multiple steps when you figure it's the cavity preparation, the cleaning of the tooth before the etching technique, the etching for a specific time, the rinsing for a specific time, the placement of the adhesive to cover all internal walls of the cavity preparation and the cavo surface margins, air evaporating off the solvent and air thinning the adhesive, and then light curing, and then the placement of composite in increments. You can realize that every step that we're doing puts the restoration at risk to contamination, to inadequately doing that part of the technique. In fact, compared to amalgam, it takes longer to place a composite resin. The adhesive technique's more costly. There are more materials that we're using to place the adhesive, and the materials we're using for finishing and polishing are in general single-use materials. For Class 2s, we have the challenge of attaining proximal contact. How do we compensate for thickness of the matrix band? And we'll talk more about that when we speak to Class 2 cavity preparations and restorations. Of interest is our patients have higher rates of postoperative sensitivity and higher rates of recurrent caries at gingival margins of Class 2s. We'll address those postoperative sensitivity in this e-lecture, and when we're talking about Class 2 composites, we'll talk about how we can address this higher rate of recurrent caries at gingival margins of Class 2s. And also composites for larger restorations show significantly more wear than that we see for amalgam. What's the current status of posterior composite resin restorations? Well, based upon the current clinical research and a statement by the Journal of the American Dental Association, Council of Scientific Affairs, we found that for routine-sized restorations and preparations with isthmus widths of 1/4 to 1/3 intercusped distance, we can consider posterior composites to be amalgam equivalents. Well, we speak about composites wearing, and many studies have focused on as composites have gotten larger, we see more wear. And so how do we look at those factors that affect composite wear? Well, for one thing, the larger the cavity size, the design of the preparation, can have a direct impact upon wear. Tooth position has an impact upon wear. How we light cure the composite has an impact upon wear. Our finishing techniques or adjustment of occlusion have an impact upon wear, as does the degree of polymerization of the resin, the type of resin used, the percent filler loading the occlusion, and the presence of parafunctional habits. And we'll look at some of these factors and what they mean. First off, the larger the preparation, the increase in occlusal wear. When we see the replacement of occlusal cusps, we'll notice increased wear. As you look on the left-hand side, you can see that this composite that's replacing the mesiobuccal cusp on the maxillary first permanent molar has flattened out and worn. On the right-hand side, this MOD large composite that's greater than 1/3 the intercusped distance for the isthmus, that we're seeing wear on that composite at 8 years, far beyond that we see with the amalgam restorations that are adjacent to it. We know that the more conservative the preparations, the less wear. Premolars show significantly less wear than molars. In fact, mandibular first and second premolars in clinical studies show hardly any wear at all, any attrition. Maxillary first and second premolars show a little bit of wear, but when we start to get to the permanent molars, we see more and more wear as we get more posterior. In fact, when you're evaluating your occlusion and adjusting the occlusion, you have to be very wary to keep the composite away from cavo-surface margins. Light curing, photopolymerization, using composites that are self-cure or using composites that are fabricated in the laboratory that are light and self-cure and pressure cured or heat cured, that we see no difference in the amount of wear. The key is our composites do better when we cure them for greater periods of time. In fact, the finishing techniques that seem to give us improvements in the wear characteristics of composite is after you adjust the occlusion on the composite, you then light cure the occlusal surface for an additional 30 seconds, and that gives you some increased wear resistance. So factors that affect composite wear: a degree of polymerization. If you're not curing the composite completely, you'll see more wear. The type of the composite: hybrids, nanohybrids are more wear resistant than flowables. Flowables you use for our preventive resin restorations. The higher the percent filler loading, the greater wear resistance that we see. Nanohybrids have more filler by weight than we see in flowables. Areas supporting occlusion demonstrate increases in wear, and so we wouldn't want to restore an entire occlusion with composite, even though we might be tempted to. Patients with bruxing and clenching habits, we see increased wear to posterior composites and the need for premature replacement when compared to amalgam. One of the areas of significant concern among clinicians is the fact that we see increased degrees of postoperative sensitivity when we place posterior composites. We see it especially in teeth that are getting their first composite restoration. In younger patients, increased amounts of postoperative sensitivity. Over the years, we've tried to define how can we decrease postoperative sensitivity, and we'll look at some of the clinical studies that have been done looking at a variety of different techniques to try to address this concern. First off, we feel that perhaps inadequate etch and rinsing may contribute to increased reports of postoperative sensitivity among patients. If the tooth's too wet when bonding, that can contribute to increased postoperative sensitivity due to microleakage. If we etch the root surfaces on areas that we're not going to restore, that by not sealing these surfaces up, that patients complain of postoperative sensitivity. Contamination during bonding, not having adequate isolation, getting saliva, hemorrhage on the tooth and just rinsing and drying it is not adequate to make sure that we're getting our adhesive interface. Inadequate adhesive drying, that we're not air thinning the adhesive, evaporating off the solvent, that once again has been identified as contributing to postoperative sensitivity. Polymerization shrinkage gaps, we see those and we feel that they may contribute to postoperative sensitivity. Polymerization shrinkage stress, putting in too large an increment of composite and light curing it for extended periods of time is not going to solve this problem for us. Inadequate light curing, and we talked about light curing in Module A of this section. The further the light is away from the composite or from the preparation surface, the more curing time we need. Orientation of the curing light is very critical. And we'll be addressing that when we talk about the techniques for Class 1s and Class 2s. Bonding agent past the expiration date. Make sure that you're rotating your adhesive materials, your composite materials. When you go to the grocery store and you're getting milk, where do you always look for the milk that you're going to purchase? You want the one with the longest lasting expiration date, and many times you'll reach towards the back of the cold case in order to get the milk out, because the ones to the front have an expiration date that's sooner than the ones towards the back. Not using your adhesives correctly, not following the manufacturer's instructions for the dwell time on the dentin, for how you air evaporate it, whether you need to agitate the adhesive, whether or not you need to light cure it, and for how long you need to light cure it for. And so all these things can lead to postoperative sensitivity. In this case, the adhesive was not properly bonded, perhaps contaminated, and when you light cured, the polymerization shrinkage pulled the resin away from the interface of the dentin. To control contamination, excellent isolation using a dental dam really makes a lot of sense. Thinking that you can keep a posterior surface clean and dry on maxillary second and first molars, mandibular first and second permanent molars, you may be fooling yourself. It's like the Amazon jungle. Your mira intraorally starts to fog up. Think what's happening to those surfaces of the tooth you're trying to bond to. So all of these come into play. Placing a Class 2 that's subgingival with some hemorrhage and sulcular fluid, even packing cord, isn't going to be adequate. In fact, the Class 2 margin at the gingival is the one that's most at risk of getting recurrent decay in all the clinical studies with posterior composites. The importance of isolation. As I said with the sealants, if you expose etch enamel to saliva for just 1 second, you have a surface coating that can't be removed with rinsing and drying. You've got to re-clean the tooth and re-etch the tooth. In fact, any contamination during the adhesive procedure needs to be controlled. And you need to drop back and repeat the last step of the procedure. Salivary contamination can lead to microleakage at that bonding interface. So what's the evidence for postoperative sensitivity? A number of different studies have been done, and this is just an overview. What if we place a liner or glass ionomer, or we use just an adhesive? Do you see any differences in postoperative sensitivity? In fact, in Akpata's study in 2001, there was no difference. You may have heard that using a self-etch adhesive eliminates postoperative sensitivity. Well, when studies were done comparing a self-etch to an etch and rinse adhesive, we saw no differences in postoperative sensitivity. What if we used a flowable composite liner acting as a stress breaker because it's more flexible, and compared that to the adhesive only? Well, those studies have been done, and we see no difference in postoperative sensitivity. In fact, we do see a lower incidence of postoperative sensitivity for deep and moderate depth cavity preparations when we compared self-etch to total etch, etch and rinse, but only in the deep and moderate depth cavity preparations. We in fact saw the same incidence of postoperative sensitivity between a self-etch and a total etch in another study in 2006, but the sensitivity decreased faster with the self-etch. What seems to be evident is that all these aspects of postoperative sensitivity are operator controlled. In fact, it may be operator specific and not material specific. In fact, one of the concerns has been polymerization shrinkage contributing to postoperative sensitivity. Placing in large increments of composite in cavity preparations and light curing those increments are causing shrinkage stress and shrinkage gaps. Polymerization shrinkage and what happens in the cavity preparation is based upon the concept of configuration factor, C factor. What's the effect of the cavity preparations themselves and the walls of the preparation on the polymerization shrinkage of a composite? The shrinkage gaps, the shrinkage stresses. In fact, C factor refers to the ratio of bonded surfaces to unbonded or free surfaces of the preparation. The higher the C factor, the greater risk for potential of disruption of the bond due to the polymerization shrinkage and stresses of the composite. In fact, a class 1 or a prepared boxy class 5 has 5 bonded surfaces. 1 unbonded free surface on the occlusal for a class 1, the facial of a class 5. It's a C factor of 5, that ratio of 5 to 1. It's a high risk for adverse polymerization shrinkage effects. We compare that to the class 3 or class 2 that has 4 bonded surfaces and 2 unbonded surfaces, the 2 unbonded surfaces being the occlusal and the proximal. And so the ratio of bonded to unbonded is 2 with a C factor of 2, which gives us a moderate risk of adverse polymerization shrinkage effects. And so when we look at class 2 and class 3 preparations, we have a C factor of 2. One of the ways we can minimize the C factor effect of polymerization shrinkage, and keep in mind occlusals have reported in the literature when patients are having postoperative sensitivity, it is that class 1 that's having the problem. We can do incremental composite placement, smaller volumes, less polymerization shrinkage, no greater than 2 millimeters in thickness. We can use a stress-breaking liner, either a flowable composite or a resin-modified glass ionomer. We can use less composite and build a thicker base. And that is the European approach to understanding and controlling the C factor of polymerization shrinkage. Or we can use a low shrinkage composite And there's a whole new family of composites that have volumetric shrinkages in the 1.3 to 1.5% range, when compared to most nanohybrid composites are between around 1.8 and 3.2% volumetric shrinkage. You need to know your composite and ask the manufacturer when you're considering a composite to provide you with that data. So what does this mean? Well, if we can get less polymerization shrinkage and less shrinkage stress, our hope is that it'll reduce the postoperative sensitivity, it'll give us a resistance to recurrent caries, and also a resistance to marginal staining. These studies are right now ongoing, and we're waiting to see if some more evidence will help guide us in how we restore teeth to minimize postoperative sensitivity. So what are our solutions to postoperative sensitivity? And once again, as I mentioned, postoperative sensitivity is an operator-controlled problem. Well, there are some things that you can do. Adequate air-water spray during preparation. There's some concern that we're overheating the pulp in the tooth and that a temperature rise of just 3 degrees centigrade is enough to cause the pulp to have an inflammatory response. We can use liners in cavity preparations, whether we're using a self-adhesive, ionic bonded glass ionomer, or an etch and rinse application of an adhesive with a flowable composite as a liner in our cavity preparation. We can use a self-etch adhesive. Currently in the dental school we don't have self-etch adhesives because they have limited applications, and our concern is that we may be using the adhesive incorrectly for certain enamel bonded circumstances. We don't want to over-desiccate the tooth during tooth preparation, tooth restoration. We don't want to blow air on the tooth to so totally dry the tooth out that we can almost see white flags jumping out of the dentinal tubules as the pulp yells surrender. We do want to moisturize the dentin, no visible moisture, but we want to moisturize it so it's glossy before we do our adhesive procedure after we've done our etch. We can use a glutaraldehyde desensitizer like Gluma or Calm It as a desensitizing agent, and some dentists have reported success using desensitizers. We never want to use a fluoride varnish. We never want to use a cavity varnish with our adhesive composite procedure. And good placement techniques in proximal boxes, where our first increment will be a flowable composite followed by our restorative composite in the cavity preparation. And the direction we're moving towards and the manufacturers are moving towards is creating formulations of composite that have less shrinkage in them. And in the last 3-4 years we've seen an increase in the number of low shrink composites that have been introduced. And then complete light curing, and we had a whole module just focused on light curing, the fact that we take it for granted and that really we need to attend to light curing because all aspects of our restoration are depending upon light curing. The other challenge we have with composites is getting a good anatomic proximal contact with Class 2s, and we'll be reviewing that in Module E when we look at Class 2 preparations and restorations. You've been viewing Module C, Posterior Composite Resins, the challenges when placing posterior composites. We've addressed all the issues and that it really comes down to good operator technique.